Hi, my name is Pamela Douglas. I'm the Geller Professor of Research in Cardiovascular Diseases at Duke University, and I am a cardiologist. Computed tomography X-ray technology has been around for about 30 or 40 years now, but only in the last decade have we been able to actually capture images of the arteries leading to the heart, the coronary arteries. And we can do that in two ways. One is to with a lower dose of radiation and more quickly just assess whether there's any calcification, which is sort of a fingerprint for blockages. Or with a little bit more radiation, a little bit more time, we're actually able to see the insides of the coronary arteries to determine whether there are blockages present or not. That would be CT angiography. There are a number of epidemiologic studies that have looked at coronary calcium scoring in relationship to subsequent events or things like heart attack or death. And they have all shown that to be perhaps the best test to predict these kinds of events. People have also done very large registries with tens of thousands of patients looking at coronary angiography by CT and shown the same very close connection or ability to predict subsequent events. The PROMISE trial was a randomized controlled trial of patients who had new onset symptoms that were suggestive of coronary heart disease. And they were randomized to receive regular stress testing or CT angiography. We anticipated the difference between these two strategies or diagnostic strategies, two different approaches, to actually be fairly small. So we estimated that we would need 10,000 patients to detect that difference. No, this was a large multi-center trial funded by the National Institutes of Health, and it was conducted in 193 centers across the US and Canada. We enrolled those patients over about 3.5 years and followed them for at least a year, at least 12 months, and up to 4 years. Well, our top line finding, our primary endpoint, was a composite, meaning any event, the first event that happened, of death, heart attack, hospitalization for chest pains, or major complications from a cardiovascular procedure such as a stroke. And we found a very low rate of this composite event, just 3% over an average of 2 years in the trial, and it was similar in both arms of the trial. So actually no difference between the usual traditional stress testing strategy and the CT angiography trial. Yeah, although the primary endpoint was not different, there were a couple of secondary endpoints that did seem to favor the use of CT angiography. One of them was that if patients went to the invasive catheterization lab, in other words, if they had to have that procedure, they were more likely to have blockages discovered if they were in the CT arm, indicating it was a more efficient triage or sorting out of patients to get to the invasive procedure. That means fewer unnecessary procedures for patients. It's an important endpoint. The other endpoint that can be important is among those patients whose doctors were choosing between a nuclear stress test and a CT angiogram. This was 2/3 of the patients in our trial, so almost 7,000 patients. The radiation was lower with CT angiography than it was with nuclear testing. We have no way of knowing whether the revascularizations that were performed were necessary or not. That would require many thousands of patients undergoing angioplasty, and there are federally funded trials underway now to explore that possibility. What we did find was about twice the rate of revascularization in the CT arm than in the functional or stress testing arm, including double the number of bypass surgeries. And usually bypass surgery is for people with very severe disease. Usually people don't get to the cardiac operating room if it's unnecessary. I know there are concerns that have been raised about angioplasty, but concerns about bypass surgery have not been raised. And so the doubling of the rate of bypass surgery suggests that more patients with severe triple vessel disease or left main disease were detected and revascularized in the CT group. So we did not compare the two tests head to head. We compared patients who were intended to have nuclear testing to those with CT, and the overall radiation dose for the first 3 months after the enrollment into the trial, which of course includes the initial test, subsequent tests if they were needed, and catheterization, was just over 2 millisieverts lower in the CT arm, which is equivalent about a year of background radiation or 20 or 30 chest x-rays. There was actually a fairly similar trial called SCOT-HEART, which was conducted in Scotland, which looked at the addition of CT angiography to stress testing. So not stress testing or CT, but stress testing and CT versus stress testing alone. And they found very similar results as we did, an increase in the certainty of the diagnosis related to coronary artery disease, and a non-significant trend towards reduction in clinical events.